Good afternoon and welcome to this session of the Tourette Association's virtual conference. My name is Evie Contolis, Development Associate and Team Tourette Manager at the Tourette Association of America. Thank you for joining us for Management of Co-Occurring Conditions. We would like to take this opportunity to thank our conference platinum sponsors, Emilex and David Amundsen, our diamond sponsor, Oracle, as well as all our donors and supporters for making this free conference possible. To help us continue to provide educational programming like this, please consider making a donation. Your gift will assist the Tourette Association of America in continuing to provide critical support and resources to the Tourette syndrome and tic disorder community. Please visit tourette.org/donate to make a contribution in any amount today. During today's session, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of this presentation. Also, the slides for this presentation are available to download under the Handouts panel on your GoToWebinar player. It is my pleasure to introduce our presenters, Dr. Erica Greenberg and Dr. Joseph McGuire. Dr. Greenberg is a child adolescent psychiatrist at Massachusetts General Hospital and an instructor in psychiatry at Harvard Medical School. Dr. McGuire is an assistant professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine.
Fantastic. So welcome everybody. This usually works way better when you guys can see us, but due to technical difficulties, it will just be audio and slides. So moving along, today we're going to talk about management of co-occurring conditions with Tourette syndrome, and it's something that many people, both educators, clinicians, parents, patients, all kind of have to deal with on a daily basis. And before we get going, though, I'll let Dr. Greenberg kind of just briefly run through her disclosures, then I'll talk about mine, and then we'll talk about our objectives for the day.
My only disclosure is that I am on the IRB at Mass General for the ECHO-PPIM trial without financial compensation and otherwise no relevant disclosures.
And she receives grant support from the Tourette Association.
And I received grant support, sorry guys, from the Tourette Association of America. The travel award, even though we are doing this, unfortunately not from Minnesota. So thank you, TAA.
And then I receive research support from the Tourette Association, American Brain Foundation, and American Academy of Neurology. And I serve as a consultant, training people how to, administer the Yale Global Tic Severity Scale and some work on anxiety through other companies. And I also have written or edited a few books and get some royalties from Elsevier, many of which I think are mostly sold to my mother. So thanks, Mom. But moving on. We wanted to kind of talk a little bit about, our objectives for the day to make sure everybody's on the same page and really think through, what we want to get out of today. And first and foremost is making sure, reviewing the common symptoms of kind of psychiatric conditions that come along with Tourette syndrome. And the next one is really discussing the evidence-based treatments for these co-occurring conditions to really make sure that, what you're doing and what you're receiving, from a provider and a patient family member perspective is really empirically supported. And then what we wanted to do is to kind of give a little bit of, guidance, expertise, and raise some kind of challenges in the context of treatment considerations. Really, going back to this question of, if somebody's getting evidence-based treatment, is it the right treatment for this, and really addressing kind of treatment considerations. Hopefully we'll be able to kind of get through all of that today, but I'll let Dr. Greenberg kind of kick it off.
So hopefully everyone in the audience has seen this graphic. If not, this is one of my favorite graphics, and I always show it to parents when I'm first diagnosing someone with Tourette syndrome. And oftentimes when parents come in for the first time, or they're afraid they must be missing something because their child appears to be having so many different disparate symptoms and or problems, showing them this picture, it can be extremely validating that the conditions that they're describing are all common and even perhaps expected when under the umbrella of Tourette syndrome. And so, as we know, tics are what one needs to meet criteria for Tourette, but often associated with OCD, ADHD, anxiety, mood conditions, sensory difficulties, learning difficulties, impulsivity, and the list goes on. And so we discuss how it's not uncommon for the tics to be the least problematic of the symptoms, and how tics only require treatment if they're causing psychological, social, or physical pain to the child, and that it is often these co-occurring conditions, which Dr. McGuire and I will talk about, that require the treatment interventions. We speak about how the goal is almost always to start with behavioral treatments, but that in some cases, the combination of medication and therapy is better than either alone. And in the more severe cases, especially when safety becomes an issue, it can be important to introduce medication sooner rather than later. Unfortunately, one of the most common reasons we might start medication without the appropriate therapy is that the family or the individual suffering with Tourette is having difficulty locating a treater and or they need help or relief more urgently. But so when I speak about medication options today, please know it is always with the assumption that someone is either in behavioral treatment and or in the process of seeking behavioral treatment. Finally, in regard to the iceberg, I explain how even though one does see all of these symptoms and conditions under the Tourette umbrella, at least from the medication side, you use the same treatments that you would even if there was no underlying Tourette. An important note about the medications I'm going to speak about today, ultimately, while we do have many, we need many more formal studies on the effects of these medications, both positive and negative, on children and adolescents. The medications I'll be talking about and or recommending are from a combination of evidence-based and empirical data. The majority are off-label, meaning that they're not formally FDA approved for children and adolescents. When I say that to parents, I also find it helpful to mention that the American Academy of Pediatrics released the statement a few years ago that, quote, off-label use of medications does not indicate improper or contraindicated use, end quote. It just means that the company that developed medication did not apply for that specific indication from the FDA. Additionally, according to a recent commentary in JAMA Ped, the prominent pediatric journal, this was when speaking about anxiety medications, though it applies to other conditions as well, the best researched medications are off-label. Some other general thoughts about medication in the pediatric population. When choosing to start a medication, you're always weighing the risks and benefits of starting it, but one should also be weighing the risks and benefits of not starting it. For example, thinking about the potential longer-term problems secondary to untreated mood disorders, OCD, anxiety, ADHD, etc., and or in terms of ensuring that the child stays on their correct developmental trajectory, socially, academically, and self-esteem-wise. Finally, I always try to remind parents that unfortunately, we do not have one single medication that treats all of the conditions one might see in a complex or more severe Tourette syndrome individual. I often give the analogy of treating complicated heart disease, where someone might have high blood pressure, high cholesterol, a history of heart attack, even AFib and arrhythmia. And even though those are all heart conditions, just like in Tourette syndrome, they're all brain conditions, that person still often needs to take separate blood pressure medication, cholesterol medication, aspirin, and maybe an anti-arrhythmia agent. So additionally, while we do have more potent medications like aripiprazole, for example, which can potentially target more than one symptom, in those cases, the medication is often more associated with increased side effects. And although, can be very helpful, but it's just weighing, again, the risks and the benefits. So therefore, when needing to treat multiple conditions, such as in the combination of severe tics, OCD, ADHD, anxiety, mood dysregulation, there's unfortunately, at least currently, a trade-off that we often have between using fewer, more potent medications with greater potential for side effects, or multiple medications, which is known as polypharmacy, with often better tolerated side effect profiles. Next slide.
So just to kind of briefly summarize, the reason Dr. Greenberg kind of went into all that is because these are going to be common themes that are going to come up as we go through each one of these common co-occurring conditions. So rather than kind of go through that at each kind of condition, really just trying to kind of put that out at the outset. And you did a fantastic job of summarizing, like, tics are what drive people on into the office. They're the visible pieces. But there's all these other kind of co-occurring conditions beneath the surface that as we start to kind of dig into, really are causing a lot of impairment, frustration, and making life hard. So we're going to kind of go through the most common ones, talk about the treatment, and I'll be talking about the behavioral or the psychological piece, and Dr. Greenberg will be talking about the kind of medication management, and hopefully we'll be able to answer everybody's questions by the end. And if I can navigate the technology piece, here we are.
So ADHD, attention deficit hyperactivity disorder. So as a reminder, up to 90% of those with Tourette have co-occurring ADHD symptoms. In terms of background, there are two subtypes of ADHD, and one can have either and or both. The first is hyperactive impulsive, and in a child, this might appear as them being constantly on the go, nonstop moving, acting before thinking. I like a phrase people use, ready, shoot, aim, and impulsive. For example, dashing out into the street without looking, or calling out the answers in class, or having problems with peers because they're more talking and doing versus watching, listening. The other subtype is inattentive, sort of like more of an absent-minded professor, distractible, forgetful, disorganized, losing things, not responding when spoken to, though not because of their being oppositional. In older teens and adults, the explicit hyperactive component may reduce, but there might be ongoing fidgeting, movement, and distractibility, excessive talking, and often reported paralyzing procrastination or poor time management. It's important to note that in ADHD, a good percent of those that have it, especially in Tourette, often see difficulties with emotion regulation. These are the kids and or adults who go from 0 to 100 in their emotions, be it happy, angry, sad. This is not a mood disorder, as the emotions aren't sustained. It's more of that rapid rise and then drop back down. The good news is that, at least for the ADHD medications, they can often treat both the hyperactive, impulsive, and inattentive symptoms and that mood up and down component as well.
So let's talk a little bit about what are the evidence-based treatments, as Dr. Greenberg started kind of getting into that a little bit towards the end of describing the symptoms. So really, when you think about the kind of core pieces, of ADHD, whether it's the kind of hyperactive, impulsive type, or the inattention, it's really setting kind of behavioral strategies to helping people develop the skills and implement the skills to kind of manage them. Sorry, I'm getting ahead of myself. So what does kind of behavioral, management kind of look like? It's identifying situations and challenges in which, patients and families kind of mostly struggle and putting in functional interventions to overcome them. So for example, if a child is really struggling to, do their homework, or if a young adult is struggling to study, figuring out, well, what's kind of distracting them? What can we kind of do to, build in a routine to kind of help them overcome it. If it's, losing, your cool or becoming really happy due to that impulsivity and hyperactivity piece, what are those kind of challenges that come on the front end that kind of trigger those situations? So one, then we kind of know, well, what are those situations that are leading somebody to be more impulsive, to be more excitable, elatable, or have difficulty controlling their mood, and then implementing kind of strategies to address that. So it may be even, trying to, not get overly excited, or, knowing that if it's hard for you to focus after you've gone and watched a movie, making sure you're not trying to study for your test right after kind of going to that movie where there's a lot of excitement going on. So it's really implementing appropriate behavioral management strategies. In terms of pharmacological management, I will turn it on over to Dr. Greenberg.
So in terms of the medication management, the therapies that are evidence-based in treating ADHD include stimulants, alpha agonists like clonidine, guanfacine, or Tenex, and atomoxetine, brand name Strattera. Stimulants are the most effective treatment we have in child psychiatry. About 80% of those with ADHD trying either of the types of stimulants get about 80% better. And overall, they're shown to be safe and well tolerated and effective. There are two main types of stimulants that you might often hear about, which can get confusing, but they're really broken into these two branches of the methylphenidate type, which is the brand names that you might hear: Ritalin, Focalin, Concerta, and the mixed salt amphetamines, and those are the brand names like Adderall or Vyvanse. While stimulants used to be contraindicated, this is kind of jumping down to treatment considerations. While stimulants used to be contraindicated in treating ADHD in tic disorders, there have been a number of converging studies over the last many years that have shown that to not be the case. Stimulants treat ADHD in those with tics as well as they do in those with ADHD without tics. So the tics does not cause the stimulant to be any less effective. And on the whole, per a very large meta-analysis, meaning looking at all of the studies combined, they did not cause or worsen tics more than placebo. That said, for any particular individual, they might exacerbate tics and not be tolerable. Sometimes if you wait a week or two, the tics then go back down again. But for some people, that isn't the case. Meta-analyses are overall versus for individuals. But ultimately, one should not be afraid to try stimulants to treat ADHD in those with tics. Anecdotally, some of my patients with tics and ADHD report that the stimulant helps them to better concentrate, to be able to suppress the tics. An important note is that in general, I and many of my colleagues tend to use the methylphenidate-based stimulants, that again is the more Ritalin, Concerta, Focalin, as they are a bit less potent in terms of their mechanism. And both anecdotally and per some literature in youth, including something that came out pretty recently, a couple months ago, they're generally less associated with potential side effects. So that's the stimulant group. The next group is the alpha agonist group. So alpha agonists are actually a relatively ineffective blood pressure medicine. These tend to be more helpful in the hyperactive impulsive subtype than the inattentive subtype per se, and aren't as effective in treating ADHD compared to the stimulants, but still a great option. What makes them particularly valuable is that they are also a first-line treatment for tics. And so if one has bothersome tics and ADHD symptoms, they could be a great place to start. Their main side effect is often tiredness, which typically resolves in a couple of weeks. It's important to know that a large study done a number of years ago in youth with both tics and ADHD showed that the combination of stimulants and alpha agonists were actually synergistic, meaning better together, when used together in the treatment of tics and ADHD. And so we can see that the combination of stimulants and alpha agonists treated tics and ADHD symptoms in these children better than either stimulants or alpha agonists alone. Finally, atomoxetine, which is also known as Strattera, is another potential appropriate ADHD treatment and has been shown to help ADHD and anxiety symptoms, though less effective than stimulants. And it's often used when someone might not be able to tolerate stimulants or alpha agonists.
Gotcha. So, and you already did a fantastic job of kind of hitting on the treatment consideration question. Do stimulant medications make tics worse? And I think the take home from what I got, and please correct me if I'm wrong, is that on the whole, the answer would be no. And in some cases, it would make more sense to kind of target ADHD with a stimulant. But for some people, if it does make tics worse, you can kind of go off that, and then theoretically the tics should kind of subside if they were attributed due to the stimulant medication. Is that correct?
Yeah. Thank you for that awesome summary, Dr. McGuire. Yes, that is correct. And I forgot another important point, which is that in terms of the timing, we know that ADHD symptoms often precede the development of tics by either months or a year or two. And so one always has to watch out for association versus causation. And so was this going to happen anyway because this other thing was acting up versus did it cause it? And so now, based on these studies, we can more safely, officially say on the whole, they definitely do not cause it. Might exacerbate, especially in the beginning, but if so, can either wait it out or may be helpful overall.
All right, thank you. So let's move on then to obsessive compulsive disorder. So, when you think, and this came up on an earlier talk, the co-occurrence of obsessive compulsive disorder, a lot of people experience this. These are worries related to contamination. Cleaning, I think, is one of the most prevalent ones. Harm-related obsessions, checking, making things sure are lined up, making sure things are neat and orderly. There's also a kind of collection or saving, or I think the common term of hoarding kind of comes on up, which can be separate or related to OCD. And there's this other kind of grouping of symptoms that we think of as is not just right sensations, where something just has to be in a certain place. And parents and families and patients will say, well, my son or my daughter or my partner's room, is a complete mess, but I can't kind of, organize it. But it's not orderly. It's not that it has to be, symmetrical. What's going on with that? And really, that's where those just right sensations are kind of coming on in. It's not that it has to be lined up. It has to be just in a specific way, in a specific angle, or the light has to hit it in a specific manner. And usually these are common amongst people with kind of Tourette's, because what ends up happening is there's this kind of urge, this sensation that we'll talk about a little bit later, that kind of comes along with this, that's similar to some of the urges people experience before having tics. So those are really the common 5 groupings of symptoms: the contamination, cleaning, checking, or kind of harm-related ones. Magical thinking symptoms, where if I don't do something, something bad will happen later on. As one patient kind of described it, he makes little bets in his head where if he doesn't tap 3 times on the table, we won't go to war in Iraq, or some other kind of thing that's seemingly unrelated, but is connected in terms of kind of that thought that he has. There's also some religious obsessions or concerns where people are worried about offending God or going to hell, even if they're not necessarily religious. But those are the kind of big groupings of kind of symptoms that people with OCD have, and in particular OCD in the context of Tourette's disorder. The first line treatment, and really the gold standard treatment for OCD, is exposure-based cognitive behavioral therapy. And this is really fantastic because when you look at a lot of the studies, OCD is something that we can treat really, really well using exposure-based cognitive behavioral therapies. And most of the treatment protocols, there's I think last it was like something like 15 randomized clinical trials, but likely many more since then, talking about the evidence for exposure-based CBT, and they all say pretty much the same thing, that it works, and it works well to treat OCD symptoms. Across all of the treatment protocols, really there's kind of 4, and I'm holding up my hand and their camera's not on, so there goes that, but there's really 4 major components. One is kind of psychological education about OCD and the kind of treatment model of cognitive behavioral therapy. The next is building a roadmap or developing a hierarchy in terms of tackling each symptom one by one, so that you're not jumping into the deep end of the pool first, because that would be pretty overwhelming no matter who you are. The third part is challenging kind of obsessive thoughts. And this kind of gets it to the thought of, well, a thought is just a thought. Well, what happens if you didn't act on it? Or how hard would it be to fight against OCD or to resist, having that, acting on that kind of compulsion or acting on that urge. And the last piece and the kind of core part of treatment is exposures. And that's really just kind of facing that uncomfortable sensation that you have to not have something just right, or facing that fear that something bad is going to happen, or facing that uncomfortable feeling of disgust, one step at a time, and starting to build a tolerance to it. And over time, people, who put in that hard work to face those uncomfortable fears through exposures get a lot better. And multiple clinical trials kind of highlight that. The American Academy of Child and Adolescent Psychiatry and numerous other kind of professional organizations really highlight exposure-based CBT as the frontline treatment for mild to moderate OCD symptoms and from moderate to severe, in combination with medication management that I'll let Dr. Greenberg talk about.
Thanks, Dr. McGuire. And so regarding medication management in youth with OCD, studies over and over show that SSRIs, or selective serotonin reuptake inhibitors, a sort of in the category of antidepressant, such as fluoxetine, sertraline, fluvoxamine, are safe, well tolerated, and effective in treating OCD symptoms. Another medication, clomipramine, which is an older antidepressant, is likely our most effective OCD treatment. However, we tend not to start with it as it is associated with more potential side effects. There was another big, very helpful landmark study a number of years ago that, like Dr. McGuire referenced, showed that the combination of behavioral therapy, the ERP, and SSRIs treated OCD better than either alone. And so that's why, especially in the more moderate severe group, we recommend starting with both the SSRI and the behavioral treatment together. To touch on this, and it applies to some of the other co-occurring conditions we'll speak about as well, a common side effect I'm often asked about with SSRIs is what we call activation. So activation, which is not mania in terms of bipolar mania, usually if it happens, usually happens after starting or increasing an SSRI dose. And this is often when the child might temporarily become a bit more silly or hyper or impulsive, may have a little more trouble sleeping. It's a well-described phenomenon. It almost always goes away, and it's more often seen in pre-pubertal youth compared to adolescents and older. The older one gets, the less likely this is to happen. If it's mild, the side effect always goes away within a couple of days to a week. However, if the side effects are more significant, or if it becomes with a lot more irritability or anger, that means that one either does need to lower the dose, which should resolve the issue, or switch medications. The lower one begins in younger kids, and the slower one goes in terms of increasing the dose, the less likely this is to happen, especially in younger kids. And for some studies, it's believed to happen in about, I've seen different numbers cited, but 10 to 20-ish%. And so it's something that I try to tell parents about so that they'll be aware of it if it does happen. I'm also often asked on how we decide on what dose. And so mainly what I explain to parents is that it really depends on what dose the child or the adult needs for symptom relief. There's not a specific dose that we're aiming for, or we know that this is going to be the right dose. I often explain that the goal is to optimize the dose, meaning finding a dose that is most helpful for the symptoms with the fewest side effects. Different people respond to different doses differently, and so someone might get a great benefit on the lower ends, although that might be a little bit less likely, and another person might get a benefit on the higher ends. It's while the older you get, maybe you need a higher dose. It doesn't necessarily have to be weight dependent in that way. That said, with OCD, it's well known from adult studies that the treatment of OCD often does require higher doses in SSRIs. And so I'll describe that to parents as well, just knowing that we might end up going up, which is okay. We're really just making sure that we're not seeing side effects. It's also important to note when talking about OCD in the context of tics and Tourette is that there are studies that tend to show that in kids with OCD and tics, the SSRIs might not be as effective in treating the OCD symptoms. However, that does not mean that one shouldn't use SSRIs to first treat OCD. SSRIs are always the first line of treatment in OCD. It could be that what's described as a compulsion might be more on the tic spectrum, or a Tourettic compulsion, which is somewhere in between a tic and a compulsion, having to tap one's arm until it feels just right, difficult to delineate. In those cases, one would need to add, if one is trying to target those symptoms, a tic treatment, since again, the treatment for tics and OCD is different. And so the medications that are shown to be most effective in helping OCD as an add-on to the SSRIs are the dopamine blockers. And these are those neuroleptics or antipsychotics, often the atypical antipsychotic. The most commonly used ones tend to be aripiprazole and or risperidone, though there are others we can speak to their doctor about. And just that they know, just how we know that sometimes alpha agonists can be helpful in treating tics off-label, it might not also be unreasonable to try adding an alpha agonist if there is also tics and ADHD in addition to the OCD. Anecdotally, I've seen some of those symptoms improve from that, but again, that's the evidence-based is speaks about using the stronger atypical antipsychotic agents. And finally, oh no, that's it. Yep, Dr. McGuire.
So, so one of the most common questions that I get asked relates to something Dr. Greenberg kind of brought up of this idea of Tourettic OCD, and I think this gets at a little bit, why some SSRIs that Dr. Greenberg mentioned, in these initial randomized clinical trials may not be as kind of beneficial for some OCD symptoms, or these not just right OCD symptoms, or what some people kind of call Tourettic OCD. So Tourettic OCD, we know OCD and kind of tics come together, but what'll often kind of happen is somebody will say, well, hey doc, I got I have tics, eye blinking, neck rolling, and I also have a lot of OCD, where I have to kind of wash my hands, or I'll check to make sure I lock the door before I left, and numerous other symptoms. But sometimes I just gotta tap on something. I just gotta touch something a certain way, and I just have to poke somebody. Is that a tic? Is that OCD? What's the difference? And I think whether you're a patient, a family member, or a professional, it's hard to kind of tease that apart, because to be perfectly honest, we don't have if this was one of the presenters previously referenced, COVID, we don't have while we have COVID tests, we don't have a tic test or an OCD test to kind of say whether or not this is a tic or a compulsion. It's really more about, how the overall phenomenology of it. From a treatment perspective, how do you kind of manage, Tourettic OCD? While there are differences between exposure-based CBT and kind of habit reversal training or CBIT for tics, there's also a lot of similarities and overlap. So some psychologists and other mental health providers, social workers, psychiatrists, whomever you're working with, can actually kind of blend the two treatments together to help somebody manage, that compulsion. So what I'll say, if it's a tapping compulsion and it's getting in the way, it's disrupting, your meeting or whatever. Well, helping to kind of recognize the urge or the thought, that kind of precedes it, and then practicing, doing something with your hands to prevent you from doing that compulsion, and placing yourself in a situation, again, where you would end up doing more of that or encountering more of that. So really blending the exposure piece and the habit reversal training piece together. So I think you can do it. It's just a little bit more nuanced, to be perfectly honest. Did you have anything to kind of add, Dr. Greenberg?
No, I think that's, perfect summary. I think one of the ways I also will try to describe it to patients and their parents, and Dr. McGuire, jump in if you do this as well. Is it more of a body sensation, or is it more is it more coming from more of a thinking thought sensation? And then if it's more body, it could be I have to tap it 3 times, or it doesn't feel just right because my hands has that premonitory urge. Maybe more tic-like versus I have to tap it 3 times, it doesn't feel just right. More of that, like that sort of more obsessive, thinking, feeling.
Or I'm worried something bad is going to happen if I don't tap it.
Exactly. Much more common. And again, it does help because it might inform, if someone has a lot of the more classic Tourettic OCD, I might be thinking, okay, we'll use the SSRI, and then we'll want to make sure we connect them with a really great behavioral therapist, because it might not target all of these symptoms that might be a little bit more in the middle.
So let's move on to oppositional and disruptive behaviors.
And so Common, so many parents of those with children with Tourette will use words like stubborn or argumentative to describe their children at times. And so perhaps maybe while there might be certain trends towards oppositionality, the condition ODD, oppositional defiant disorder, has specific criteria that one would be required to meet. And it's a combination of angry, irritable mood, argumentative and defiant behavior, and vindictiveness. So in individuals that are diagnosed with ODD, ADHD is a very common co-occurring disorder. Regarding treatments, we don't have any in individuals, we don't have any medications that target ODD per se. However, if one treats the co-occurring disorder with the appropriate medication, for example, in co-occurring ODD and ADHD with either the stimulants, alpha agonists, atomoxetine, the ODD symptoms, including the disruptive and aggressive behaviors, may improve. And I'll let Dr. McGuire talk more about the behavioral management, and then I'll add one or two things about the pharmacological management.
You're too quick, Dr. Greenberg. You're too quick. You're jumping all the way down too fast. So, you know, as Dr. Greenberg said, these are kids who are strong-willed. These are kids who, you know, might kind of fly off the handle a little bit quicker, and they're being disruptive. You know, when they don't get their way, they're throwing a temper tantrum. When, you know, you try to say, oh, hey, can you do this? And they're clearly saying, no, you know, we're not doing this. And it's hard, right? Parenting in general, as everybody's going through this kind of crisis in the world, is hard enough. You know, I think parents are, you know, challenged and kind of put in situations that are just, we're asking so much of them. So one way we kind of help parents, you know, manage kids who are more oppositional, who are disruptive, is through parent training. And that doesn't mean you're not doing a great job of parenting. It just means every kid is different, and there's different types of strategies that we can help, you know, parents apply adeptly to manage and kind of, you know, sidestep a lot of these oppositional and disruptive behaviors. For kids, you know, as Dr. Greenberg mentioned, you know, that tend to have a little bit shorter fuse where they fly off the handle pretty quickly. You know, for those, and that tends to be a little bit more adolescence. That's where, you know, anger management training really works well, learning how to manage your frustration and kind of tolerate that. So there's been at least 2 trials, one of each, looking at parent management training to help parents, you know, address disruptive behaviors in children with Tourette syndrome. And that was done, I want to say, in 2006 by Larry Scahill, and then another one in older adolescents with Tourette's who had anger management issues, done by Dennis Sohodelsky back in 2009, I believe. And what they both found is that these therapies work really well to help address these oppositional and disruptive behaviors, teaching parents how to kind of parent and apply these skills of positive praise, setting up consequences for oppositional and disruptive behaviors in a stepwise fashion, really helped reduce the occurrence of disruptive behaviors over time and over the course of participation. Same thing with the anger control training that Dr. Sohodelsky developed specifically for adolescents with Tourette syndrome. So these work in clinical trials, which is great. And really kind of highlights the potential to really, you know, give parents and kind of young people tools to kind of manage these strong emotions. What you see a little bit more in older adolescents and adults, and this, to my knowledge, hasn't been shown in clinical trials, but this is more clinical anecdotal evidence, is emotion regulation skills, mindfulness skills, for when people are getting, you know, really worked up, really frustrated, really stuck, helping to bring in that flexibility and practicing that. The hard part, if you're an older adolescent or young adult, is, you know, usually it's not, you know, you have to be interested in identifying this as a problem and wanting to put in that work. Whereas for children and younger adolescents, you know, mom or dad or grandma or grandpa can kind of bring you to treatment to kind of help get you there. but I'll let Dr. Greenberg kind of follow up on the stimulant question, and then we'll talk about the kind of treatment consideration.
Yeah, and no, I think it's just so important what Dr. McGuire mentioned regarding having the behavioral therapy in this be so helpful, because one, this can be just so disruptive for families, and two, we don't have any treatments that are specifically targeted for that. And so just to reiterate what I said before, because ODD often, or the more difficult behaviors, disruptive behaviors often occurs in the setting of ADHD, one sometimes sees benefit from using the medications to treat ADHD as one would even if there wasn't ODD. So that can be helpful. What we sometimes do off-label for more severely aggressive behaviors, or intermittent explosive disorder, which is when one has rages at least twice per week following small triggers, having these large rage episodes on at least a few occasions, resulting in physical property damage or physical injury. One off-label could start with an alpha agonist. If you remember, that is what we use to treat ADHD. It's one of the ADHD treatments, and it's sometimes helpful, but if not, the treatment of choice often becomes short-term neuroleptic, again, that atypical antipsychotic, such as risperidone. But in those cases, as in all of them, it's just crucial that the family is involved in the behavioral treatment. The other thing that I like to say about oppositional behavior is it can often be mistaken and actually be driven by anxiety. And so one of my colleagues, I liked this phrase, described that in terms of how children express anxiety, some express it as turtles and some as tigers. The turtles withdraw when they get anxious, but the tigers might look oppositional, defiant, rageful, but it might be because that is their reaction to the anxious situation. And so it can be helpful to see if these behaviors only occur in settings that may be provoking anxiety, because if that's the case, one would want to make sure to treat anxiety versus oppositional behavior. And then in terms of which to treat first, and then I'll turn it back over to Dr. McGuire, what we really say is whichever is more disruptive. And so if the tics are causing impairment, however, the child is, there's a lot of destruction going around the house, one might say, okay, that right now is more about safety, and would treat that first, but it really depends on the scenario.
I love that, turtles and tigers, which also sets up perfect for the next piece. We know a ton of people who have Tourette's also have an anxiety disorder. And when you think about, I'm not going to list all the symptoms, but they really fall into three broad domains, and they vary across people. First and foremost, you have the physiological symptoms. These are the fight, flight, or freeze responses. That can be a panic. They can be numerous other things. We're getting the wrap-up cue. Got it. So they can be kind of physical sensations. These are panic, tightness in the chest, difficulty breathing. These are worry thoughts that keep you up at night. So you have the physical symptoms, you have the thoughts. So these are worries about something bad happening to mom or dad, or worries about being embarrassed. And then the behaviors. These can be mainly in anxiety avoidance behaviors. I'm worried that people are going to, think badly about me, or I'm worried, people aren't going to like the tie and shirt combination that I wore. So all of a sudden I'll avoid having my web camera on. So I appreciate the courtesy laugh. So these are kind of common things that kind of happen. The benefit to, from that is that we have really great treatments for anxiety. First and foremost is kind of cognitive behavioral therapy, CBT. So what CBT does, pretty similar to exposure-based CBT, is it addresses, first provides psychoeducation about how your thoughts and feelings and behaviors are all interrelated to one another, which I think is an important piece to kind of remember, because one can really influence the other, and as you change one, you'll start to see changes in the other. And follows that same kind of broad 4-component model of kind of psychoeducation, building a hierarchy, meaning we want to put all those things, in a general order so that we're not jumping into the deep end of the pool first, challenging the anxious thoughts, and then starting to kind of face those fears through exposures. And part of those facing the fears might even be removing accommodation and removing the avoidance. So it would be turning on my web camera, once I feel that I'm able to kind of manage the anxious thoughts and kind of have the skills to manage those physiological sensations, and starting to put yourself in those moments to start to tolerate that distress and not have that fear and that anxiety impede your life. I'll let Dr. Greenberg talk about the pharmacotherapy, and then I know we want to try to at least get to a few questions. So
yeah, and then our mood disorders quickly. So like OCD, SSRIs, again, that's the fluoxetine, sertraline, are the gold standard medication treatment for anxiety. In pediatric populations, interesting, duloxetine, brand name Cymbalta, which is an SNRI, serotonin norepinephrine reuptake inhibitor, is the only FDA-approved medication for anxiety in youth. But again, as that JAMA article stated, the best and most researched treatments of pediatric anxiety are off-label and SSRIs. There's also, we know about in anxiety that the combination of medication and behavioral therapy is synergistic, so the combo is more effective than either alone. And so when one is going to treat anxiety, one should start with SSRIs, that again, gold standard first-line treatment. However, if there is difficulty tolerating SSRIs for whatever reason, it would be prudent to try an SNRI. After analyzing multiple studies, a recent meta-analysis study showed that they are a bit better tolerated regarding side effects and that activation I spoke about, but they're also not necessarily as effective or quick to benefit. Buspirone, brand name Buspar, is a medication with a generalized anxiety indication, safe, well tolerated, few side effects, mixed results in trials, sometimes not better than placebo, but a good option if one has trouble tolerating SSRIs or SNRIs. Very briefly, in terms of how long it might take for the medications to work, it used to be thought that it would take a while, but recent data has shown that one is most likely to have about 2/3 of the benefits within the first 2 or 3 weeks, followed by ongoing but less notable changes over the next 1 to 2 months. And then finally, just some medications we also use off-label, not first-line treatment, but sometimes temporarily while we get a more longer-term solution in place, includes alpha agonists, clonidine 10x, beta blockers, the heart rate medicine, propranolol, hydroxyzine, which is an antihistamine, gabapentin, and rarely, especially in kids, but very occasionally, benzodiazepines like Ativan or clonazepam. Yeah, go ahead.
So no, I was just going to try to move on to the mood disorder selection kind of overview, so we can at least maybe get to 1 or 2 questions before we have to break. Short answer: will treating anxiety lead to improvements in tic severity? It can, but none of the medications and none of the CBT that we briefly described here will specifically reduce tic severity. We know tics and anxiety. We know anxiety can make tics worse, so it may indirectly improve tic severity, but not necessarily. In terms of common mood disorders or common mood symptoms, did you have that one, Dr. Greenberg?
Yes, at least a little bit, and then you can
Sure.
add on. So we know that mood disorders are a common co-occurring condition in those with Tourette. We also know that one could develop depression independently or secondary to having other severe symptoms over time. It can be difficult to differentiate, though sometimes if it's very clearly secondary to circumstances, we might think of that as more of an adjustment disorder or demoralization versus an independent depression. And again, just in contrast, when we were talking about ADHD, we had said how a lot of those individuals would have this mood lability, this quickness of up and down of mood states. That's compared to mood disorders, where the mood state is sustained. And so mood disorders, we're talking about mainly depression and bipolar spectrum disorders. In children and adolescents, it's important to note that depression states might appear more as irritability rather than sadness. And that as one gets older, the depression symptoms become more what one expects, more of the melancholy, lower or increased appetite, tiredness. But in kids, it can be more of an irritability picture.
Got it. So in terms of evidence-based treatments for a therapy piece, and then we'll go through the meds, and I think we may have time for 1 or 2 questions. Really, behavioral activation is a kind of one of the 2 core treatments, and it's really getting out and kind of doing things, or as I'll sometimes tell my patients, you got to fake it until you make it. So, by doing more fun things, it actually starts to elevate your mood. For another kind of gold standard treatment is cognitive behavioral therapy. CBT in this differs from CBT for anxiety because the emphasis is more on challenging those kind of thoughts of worthlessness, hopelessness, really evaluating the evidence, and then bringing in the behavioral activation of doing things until you start to kind of feel better. And I'm giving it a pretty quick overview because I want to try to make sure we at least wrap up.
In terms of the pharmacological, we do use SSRIs again to treat depressive type disorders. That said, we do know, at least in children and adolescents, they're not necessarily as reliably effective as they are in anxiety or OCD. We already have enough reasons why it's important to have both the medication and or the therapy, but even more so why one needs that behavioral activation as well. If the condition is more consistent with a bipolar spectrum disorder or severe mood dysregulation, and I think that is sort of a whole talk upon itself, how to differentiate, one might consider adding a mood stabilizer. Mood stabilizers encompass a variety of medications, some in the anti-epilepsy category, also the atypical antipsychotics I've mentioned a lot, the aripiprazole, the risperidone. And at least for the atypical antipsychotics, they do have that dual benefit of helping both the mood and tics. However, one needs to use very judiciously, as they do have the more potential potent side effects. A final medication to mention that does have some off-label benefit in ADHD and also shows evidence of effectiveness definitely in adults and in children and adolescents as well for depression is bupropion, also known as Wellbutrin. And so sometimes that could be a medication that can help both with mood and ADHD symptoms combined.
Got it. So we wanted to at least squeeze in 1 question if we have time, or we may be right.
I apologize. So we actually, unfortunately, we do not have time for any questions, as there's another session that's coming up right after this. But I will be forwarding your questions to the presenters as we will get you some answers in the next few days. Thank you so much, Dr. Greenberg and Dr. McGuire, for a wonderful presentation. This is all the time that we have for our conference session. Once the session is closed, you will receive a survey on the presentation. We would greatly appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of the session. CEU credits are available for this session at an additional fee. Visit Tourette.org for more information. Additionally, the session will be posted on the TAA's YouTube channel for those who are unable to participate today. We encourage you to reach out to us about the virtual conference or for other ideas and suggestions you may have. This presentation was presented free of charge thanks to our generous donors. If you appreciate this session, we welcome you to support the organization. Visit us at Tourette.org to learn more and donate. On behalf of the Tourette Association, thank you again for joining us and taking the time to view this presentation. Have a great day.
Thank you, guys.
Thank you.